Can you all hear me well? Lokesh, Dr. Lokesh, can you hear me well?
Can you hear me?
Yes.
Vijaya is not, we're not hearing any.
Yeah. Can you hear me? Can you hear me well?
Yes.
But with the headphones, we can hear you, Dr. Reddy.
What is that?
With the headphones, we can hear you clear.
Oh, okay. Good evening, everyone. Thank you for joining. I'm sure more will join soon. First of all, I'm Dr. Suresh Reddy, the president of AAPI, and this is the first virtual CME we are organizing. So there are some technical glitches. Please pardon us. We apologize for technical issues, but we'll try to make it better. This is just a rehearsal. The final show will be during the last week of June, and we'll have a bunch of CMEs at the time. This we would especially like to thank the Chicago Medical Society for providing us with this accreditation. As you know how difficult it is to get CME accreditation these days, and Chicago Medical Society has graciously and kindly accepted and agreed to give the CME for us. There are a couple of housekeeping things. The most important thing is please write your name in the chat box for our cross reference so that we can issue the CME certificates, and also please write your email address, your name and email address both, so that when we give the certificates we'll have your email address, because some of you have not registered. So please write your name and email address in the chat box. And thank you again for joining. We have Dr. Lokesh Idara and Dr. Seema Arora moderating the session today. And we have some proctors from the Chicago Medical Society. And CME will be given to only who has a video enabled. If you are joining on the phone, unfortunately, we cannot give CME. So please join on video and put your picture on. You can at least intermittently, you don't have to keep your picture on all the time, but at least keep the video on intermittently so that the proctors will know you are here. Thank you for joining, and welcome, Dr. Idra.
Can you hear me, Suresh?
Yes.
Can you hear me? Can you hear me, Suresh? Thank you, Suresh, for this the first CME, as Suresh said, from the AAPI and webinar. I will go introduce, Seema, you want to introduce Dr. Krishna Kumar, or you want me to go ahead? Let me introduce Dr. Krishna Kumar, MD, FA, AAPI, FA, CEP, Clinical Professor of Pediatrics and Emergency Medicine, New York College, Osteopathic Medicine, New York. And he's attending physician, Department of Emergency Medicine, New York Presbyterian, Queens, New York. Ex-chairman and program director of Department of Pediatrics, Nassau University Medical Center, and ex-medical director of Fire Police EMS Academy. He's also COVID survivor, and Dr. Krishna Kumar sir will talk about pre-hospital care and COVID-19. Sir, Krishna Kumar, go ahead, sir.
Thank you. Thank you, thank you, Lokesh, so much for the wonderful introduction. First of all, I want to say thank you to AAPI for organizing this first time virtual CME. A lot of work is involved behind the scene, and I'm really surprised and amazed to see how AAPI came up with the 1.5 CME credit hours. Thank you to Suresh and Seema and Lokesh and the whole team which has been working behind the scene to get CME to all the participants. My name is Dr. Kumar. Basically, I deal with EMS and emergency medicine. A few things I would like to just address. Okay, I do not know how to work on the screen. Go back on this. Okay. In the COVID-19, most important thing is the pre-hospital care. The reason being, there's no treatment for the COVID-19. Once you get infection, you got it. Nothing can do. But what we can do, we can prevent COVID-19 to get worse. That is the whole idea. There is no vaccine for it. There are no proven modalities for coronavirus treatment, neither hydroxychloroquine or plasma, remdesivir or CPAP, BiPAP. Basically, treatment is supportive. So key thing here is the prevention. How do we prevent the infection? Most important thing here is to protect yourself and your family from coronavirus. Everybody should be washing their hands with soap and water for at least 20 seconds. At least for 20 seconds. And most of my slides are from CDC and New York City Department of Health. I just put on the screen here. Can you guys see all this? How do you wash the hands? First, wet your hands, get the soap from soap dispenser before.
Little bit louder, sir.
Little bit louder. Now it is better?
Yeah.
Okay. Put your hand under the sink, wet your hand, and get the soap on your palm without touching the soap dispenser. Okay. There's technique to it. It is 1, 2, 3, 4, 5, 6, 7, 8. You can see it on the screen very well. How do you wash your hands? Right? At the same time, you should not be touching your eyes and nose and the mouth with hands. Extremely important. What happens inadvertently, we touch the surface, we shake hands, or somebody sneezing, or you sneezing, right away you put your hand on your face. Please don't do it. At the same time, you need to avoid sick contacts with the other people. At the same time, people may not be sick, they may be asymptomatic, so you should not be going closer to them. CDC says at least try to keep yourself at least 6 feet apart. That is the only thing that is shown to decrease the spread of COVID-19 infection. They say once you sneeze or once you cough, the virus could be shed in the droplets. It can stay in the air for a few hours, 2 to 3 hours, usually up to 3 feet distance. For a safety reason, we're keeping it 6 feet distance. So please maintain a social distancing of at least 6 feet. At the same time, if you happen to sneeze or cough, please use the tissue or you can sneeze into your elbow. Extremely important. You do not sneeze in the open air. You have to sneeze in your elbow. At the same time, you have to keep washing your clothes, utensils, and the surfaces with the disinfectants regularly. You have to do that. For the people who are sick means they have a fever, they need to stay home. Right now, if you have fever, if you have sore throat, assume you have COVID-19 infection. Or if you have fever, a cough, anything, any kind of that symptomatology, think you have COVID-19 infection. What that means, you need to isolate yourself. If you're somebody with sick ones, you need to quarantine yourself at least for 10 days. After 10 days, if you see you're not getting any fever for at least 72 hours. That too, in that time, 72 hours time, you don't take any
You are on two things,
no
okay?
painkillers like acetaminophen or Motrin. Don't take any medicine. You need to be fever free without the usage of
Did you
acetaminophen
hang up the other
or
one?
Motrin. If you have somebody who's sick in your house,
You are signed up only one unit, right? One unit.
if you have somebody who's sick in a family, try to isolate that very person in a different room. If you don't have to share the same bathroom, please don't do it. Okay? Make sure you don't share the utensils or clothes or towels or sheet, anything. Everything has to be separate. At the same time, try to disinfect your house, surfaces, anything. With disinfectant, you can make your own. Take 1 cup of the bleach and five gallons of water, mix it together. That makes a good disinfectant. At the same time, you don't have to share somebody else's items. Okay, if you think you're getting worse or you need more information, make sure to make a phone call to the doctor first. Just don't show up to the doctor's office. As ER physician, many times we are sitting in the EMS booth where we get all the 911 calls. And our job is to determine which patient needs to come to the hospital, which patient does not need to come to the hospital. Basically, we were told, look out for 4 symptoms like fever, cough, shortness of breath, or sore throat. If you have any of these 4, think you have COVID-19. The thing is, if you have COVID-19, you need to stay home. That is the bottom line is. You do not go to the hospital. You do not go to see a private doctor if you don't have shortness of breath. Only time we would encourage people to come to the hospital when they cannot breathe or they have a heavy chest pain. At the same time, we tell them, if you want to come to the hospital, please do not even call 911. If you think you are really, really sick, call for a cab and that cab will bring you to the hospital. Make sure in the cab, you sit in the back seat. Extremely important. You sit in the back seat, all the 4 windows open and make a full blast air, no air conditioning there, okay? And you wash your hands and disinfectant all the surfaces before get inside the car. When you get out of the car, make sure everything is disinfected again. At the same time, if you have to go to the hospital, try not to go with your relatives. Try to go by yourself. Reason being, if somebody who is going to be with you, good chances are that person will be infected too. All right. And what we do in the ER anyway, it is all supportive treatment. If in case patient does not have COVID-19, if they come to the hospital, the good chances are they will get COVID-19 infection. They say it is a droplet infection, and they're still debating whether it's airborne or not. We all know that the size of the coronavirus is 0.125 micron. What that means, N95 mask, what we have, it can filter not less than 3 microns particle. And coronavirus, COVID-19 virus is much smaller than 0.3, it's about 0.125. So it's not a good idea. Us, as a physician, we need to prepare ourselves to make sure we are properly gowned. Okay. Now, if the patient can stay home, that's the best. If he has a job, all he has to do, tell his employer, we cannot come to the work because I got COVID-19 or COVID-19 like symptoms. And in New York State, I know for sure there's no penalty for not showing up to your job. If you're hungry, if you need something, tell one of your friends to go get the groceries for you. Or you can ask somebody to deliver the goods for you too. All right. Now, our as ER physician, we need to determine what the patient right now. Okay. Sometimes patients are not very happy when you tell them you stay home and they want to talk to the doctor. So please tell them, just don't show up in the office and make sure you call your physician first. Because these are the physicians who know you the most. If they feel patient needs to go to the hospital, only then they will encourage you to go to the hospital. For the kids, it's a little tricky. For the pediatric population, anybody who's less than 2 months of age, who has a temperature of 100.4 degree Fahrenheit, or patient may not have any fever, but at the same time, he's a high risk. He got high risk comorbidities like sickle cell disease, he got central lines, he got a cancer, he's on on chemotherapy, or he's neutropenic, or is significantly immune compromised. Those are the patients you want to see in the hospital right away. Okay, a patient cannot breathe, or patient is not urinated in the last 24 hours, other than 3 wet diapers, that patient has to come to the hospital. Anytime you think patient got kind of lethargic and he's not behaving regularly how he's supposed to behave, please, you want to see the patient in the ER right away. Our patient got vomiting and diarrhea. Okay. Now, for symptomatic management, what we are telling the patient what to do, for fever and body aches, just take good old medicine, that is your Tylenol, that is your friend, acetaminophen or paracetamol. At the same time, there is no clear evidence that NSAIDs like ibuprofen or naproxen are harmful to the patient. If the patients are more comfortable, it's okay, they can take that too. All right. Otherwise, just tell them just take Tylenol only. For cough medication, cough syrup, we do not recommend anybody who's under less than 6 years of the age. No cough medicine, please. Over 6 years, if you have to give somebody cough medication, just give simple plain guaifenesin, robitussin, or dextromethorphan. You can do that. Now, another symptom which you're seeing in a lot of the patients, these people are losing the sense of smell, sense of taste. They cannot smell anything. Those are the patients, we tell them just take fluticasone, Flonase nasal spray. Okay. For loss of taste, that takes time, maybe few months, people will get it. And tell them, hey, you are sick, take a lot of electrolytes, a lot of fluids. What you like the most is the Gatorade or Pedialyte, especially flavored Pedialyte. Don't give the regular old Pedialyte. It has to be flavored. Otherwise, let them drink Gatorade as much as they can. Then let them have Gatorade. And time to time, we keep calling our patients. We want to know how they're doing. Sometimes what happens, they are so scared because of all this media too, they do not want to go to the hospital or to see any doctor. Or we tell them, hey guys, if you're getting worse, especially we cannot breathe, that is a red flag. Please come to the hospital. And worst thing with the COVID-19 is, you never know which way patient is going to turn around. So your second week of illness, they get rapid deterioration in respiratory function. So you have to be really on the top of everything. All right. And if you're with somebody who got this problem, then you want to train or you want to teach or you want to educate the family member too, what they should be looking out for such patients. Right? And our governor has mandated social distancing. That means 6 feet apart. They should be staying home as much as they can. And if not, maybe some penalty. For us as a physician, you must be fully protected. If you're not protected, chances are you will get COVID-19. I got COVID-19 in spite of doing all that too. So it is very scary disease, tell you the truth. And be prepared, please, be well protected. You must have full gown, okay? Boot is there too, face shield, goggles, and gloves, N95 mask or higher. If you can have P95, get that too. Best I like the most is a PEPPER. It's a powered air purifying respirator. That is the best for the protection of the individuals. Thank you so much. If you have any questions, we'll be all available in the last, when we conclude our all the 4 speakers lecture. Thank you so much for listening to me. Thank you.
Thank you, Dr. Krishan Kumar, for that very educated talk, educating us about this indeed very, very scary disease. We are still trying to figure it out and protect ourselves. So thank you very much. And our next speaker is Dr. Sangeeta Rangala. She is the medical director at Edward Hospital Care Center and works at the emergency room of Edward Hearts Hospital. Dr. Rangala, please take over.
Hi, everyone. Thanks so much for organizing this. And thanks so much for creating this CME and making me part of it. I really appreciate that. I'm going to share my screen, and please let me know if anything does not work here. Great. Are you able to see the PowerPoint? Could someone just say yes for me?
Yes, yes, it's
Okay,
working.
thank you. All right, so I have kind of a two-part talk. One is on atypical presentations of COVID, and then given that we have these atypical presentations, how do we keep ourselves safe in the ED? How do we prepare the physical space? And what sort of protective gear are we wearing that Dr. Christian had touched on a little bit. So atypical presentations. First, let's start with the typical. I think we've all heard the fever, chills, cough, shortness of breath, and then the new loss of taste or smell, the anosmia, dysgeusia. The viral, we also see the viral syndrome type symptoms quite often, fatigue, muscle aches, body aches, headache, sore throat, and then runny nose, congestion, URI type symptoms. The less typical things that we're seeing are GI symptoms, diarrhea, nausea, vomiting. At this point, honestly, the diarrhea, nausea, vomiting has occurred commonly enough that it's made the CDC list of symptoms. And I have to say, in the ED, if I'm seeing a patient with bad diarrhea, I'm pretty sure it's COVID or needs to be tested for COVID. Loss of appetite, abdominal pain, and then the finding of terminal ileitis, CT, has come in quite often as well. Non-specific presentations, lethargy, syncope, altered mental status, especially in the elderly, there are a lot of non-specific symptoms, just confusion, incontinence, weakness, sort of like we see with urosepsis patients. And then there's this sort of, for lack of a better word, dwindling. There are a lot of patients in group settings, nursing homes, assisted living, who are isolated to their rooms for safety reasons, and therefore they don't get exercise, they don't get a whole lot of human interaction, and they just have become slowly deconditioned over time. Silent presentations in COVID. So there are a lot of asymptomatic pneumonias, a lot of silent hypoxia, despite the findings of bilateral viral pneumonia. In fact, there were a lot of patients who had no respiratory symptoms whatsoever, but had abdominal CTs for abdominal pain, and at the base of the lungs were found to have viral pneumonia. So the findings there are things like this ground glass opacities, air bronchograms, and then crazy paving, which honestly I had to sort of relearn what crazy paving is, but it's the ground glass opacity with the thickening of the interceptal thickening, and then it creates this sort of stone-like pattern, like stone pavers. Other things, the more visible presentations, I think we're seeing more and more of these COVID, let me start with conjunctivitis. It's generally bilateral without other causes found. And then the skin findings, I think we're seeing more and more pictures of COVID toes that look, or COVID fingers that look like Pernio or Chilblains type findings. There's also sort of the usual viral exanthum, maculopapular, morbilliform rashes. There's also a lot of urticaria that we're seeing, petechiae in little pinpoint forms, and then coalesced into purpura. There's erythema multiforme with the little target lesions, vesicular rash, almost like a chickenpox, and then the livido reticularis. So those are some of the visible findings. The things that we used to think about less, but are seeing probably more and more of, are just chest pain, palpitations, abnormal EKGs with myocarditis, thromboembolic events like stroke and PE. And these patients, unfortunately, we're seeing a lot of late presentations because, again, patients are scared to come to an ED for fear of catching the coronavirus and becoming COVID patients. But unfortunately, we're seeing a lot of late arrivals for stroke and MI where there was a possibility for intervention. There's also, I haven't seen this, but there's reports of Guillain-Barré following COVID. And then there are a lot of just, and I think we're seeing this more and more, autoimmune mimics. So rheumatic and lupus type symptoms. Lupus is already known as the great imitator. And I think we're seeing more and more of that with COVID patients. Now, so with kids, so in infants, there can be a lot of just completely non-specific findings: hypotonia, drowsiness, difficulty feeding. And then in children, fever with no other source, not even URI or viral syndrome type symptoms, just fever.
Can you speak a little closer?
Oh, sorry.
Sometimes,
Okay, is this better?
Sometimes, yeah.
Okay.
Yeah.
And then there's the MISC. There are other acronyms for it, but it's basically a multi-system inflammatory syndrome or disorder. And it looks sort of like Kawasaki or toxic shock. In other countries that had a peak in COVID patients, the peak of this MISC tends to be 3 to 4 weeks after the community peak. Since we've had in many parts of this country a much more gentle curve and not a big peak, it's not really clear how we're going to be seeing this, or if the patients are just going to be rolling in more slowly. It's more present in Black patients, in older children and adolescents. The pulmonary symptoms are not generally the prominent presentation. And it's a warm shock. They're refractory to volume. They often don't respond to volume resuscitation. They require pressors. And there's a CDC and WHO definition of criteria. I'll just go over, oops, I'm missing a slide somehow. Give me 1 second. I'll just go over this. The CDC, it's a busy slide anyway, but the CDC definition names hospitalization as part of the criteria. They both require multi-system organ involvement, at least 2 systems or more. They both require the patient to be either 19 or 21 years of age or younger, fever, and then elevated inflammatory markers. The CDC also recommends considering this syndrome in patients who meet some of the criteria for Kawasaki's. And of course, all of the patients have some sort of exposure or a positive test for coronavirus. Okay, so when all of these atypical presentations are around us, how do we separate COVID? We have to sort of assume that everything is a possible COVID, even though we know not everything is COVID. So now we're going to go into ED safety and preparedness and our physical space and PPE here. Here we go. Can you see the screen okay?
Yeah.
Okay. Oops. Let me just get back to that. Had a little computer misfire there, sorry. Okay, so these were the MISC criteria. I can share that in the slide set afterwards. So we've finished the atypical presentations with the silent respiratory findings, GI, non-specific, skin, eye, mucocutaneous, neurologic, cardiac, thromboembolic, autoimmune, and then what we found in children. Okay, so now going to ED safety awareness. Everything is possibly COVID, so keeping our physical space and our PPE ready. So first thing we've tried to focus on is just cleanliness. Starting with the physical space, we've increased housekeeping staff. There's a 1-hour downtime after any aerosolizing procedure. There's a ceiling to floor wipe down of every room, and then additional cleaning of high-touch surfaces. We've deployed our labor pool quite a bit. So even our really senior nurses are actually doing a lot of cleaning and other sort of basic tasks for us. At the entrance of the hospital, everyone gets hand sanitizer. There's a no-touch thermal scanner for temperature. Everyone gets masked. Everyone gets screening questions. There's social distancing, and we have very, very limited visit policy. On the floor, there are no visitors. In the ED, we get 1 and maybe 2 for small children or people who really need someone with them. So this is our entrance. You can see the blue tape that I think we're seeing at more grocery stores also. And then at the end there is where all the screening takes place. Also trying to separate the patients once they, anyone in the waiting room, they immediately, they immediately get roomed into the ED. Negative them, and also have a tent with negative pressure ventilation outdoors. So we try to separate as much as possible. We know that a patient has respiratory symptoms or something where aerosolizing processes might occur. Then there are separate pathways to each of the pods. There are closed doors, and then family. They can do so by baby monitor and forth into the room. There's a patient assigned a stethoscope instead of us using our equipment and going in and bringing it back out and potentially creating a foment. So PPE, there is a global and nationwide shortage, as we all know. So we're trying as much as possible to switch to reusable supplies. So for N95, P100, there are these, the 3M full and half face respirators. These are essentially usable until they're contaminated. Even in industrial settings, they're supposed to be good for 30 days or even longer. This is the Endo mask, very, very comfortable. We've purchased this at our hospital, also reusable. Just the little white filter on the inside gets changed. And that can also go through a sterile process. We're working on Raj Iyer, who's with our analytics team. Actually, he has been working on a modified Montana 3D printed version with a gasket that has passed port account testing with flying colors. And then there are these face shields. This portion is 3D printed, and then it's just a clear plastic that's attached to that. Those are also completely reusable, and our local robotics club actually made those for us. And then of course, the single-use N95s have become multiple-use gowns we have that are reusable. We're washing all of our PPE, reusing the gowns either through washing or STERRAD, and then the ultraviolet box gets all of our supplies as well. So we're trying really hard to get out of the supply chain. So I think that's my time. Atypical presentations in ED safety, and any questions, I'm happy to see what I can help with at the end. Thank you.
Thank you so much, Sangeeta. Go ahead, Sim.
So our next speaker is Dr. Einstein. He's board certified in internal medicine and emergency medicine. He's assistant professor of Washington State University and emergency physician at Providence Regional Medical Center, Washington. Dr. Einstein.
Good evening, everyone. Thank you for giving me this opportunity to deliver this lecture. So let me do this screen sharing. Are you able to see?
Yes, yes.
Okay, today I am going to talk about the emergency airway management in the COVID-19 patient. So the objective of my talk is at the conclusion of this presentation, you should be able to know the indications for intubation of the COVID-19 patient, describe the complexities involved in the intubation of COVID-19 patient, the rationale behind the suggested safe intubation practices. So the main principles, there are three main principles, is to minimize aerosolization during the procedure and maximize the first pass intubation success and to limit contamination. So what is the rationale behind these principles? The evidence comes from SARS epidemic in 2003. So a retrospective case control study was carried out to identify factors associated with SARS transmission in healthcare workers who participated in intubation of SARS patients. There were 91 intubation procedures identified in 4 major hospitals in Hong Kong during the period of the study. 8 resulted in infection of at least 1 healthcare worker. The investigators found that procedures resulting in transmission of disease were usually associated with difficult intubation, extensive bagging, and extensive droplet contamination. So this is the association of endotracheal intubation with the development of SARS among physicians and nurses. This is a retrospective cohort analysis in ICU at Mount Sinai University Hospital in Toronto, Canada. So the authors examined the risk of developing SARS in physicians who performed endotracheal intubation versus physicians who cared for the SARS patient but did not perform intubation, and the nurses who were present during intubation of SARS patient versus nurses who took care of SARS patient in ICU but were not present during intubation. So among all healthcare workers, there were 14 healthcare workers who were involved with intubation, and 6 of them developed SARS. And 62 healthcare workers took care of SARS patient, but they were not present during intubation. Only 2 developed SARS. So the relative risk of developing SARS during intubation is 13.29. The p-value is statistically significant. So this is another retrospective cohort study designed to identify risk factors for transmission of SARS to health workers during intubation. What is it that makes intubation a risk factor of contracting SARS to the healthcare providers? So what they did is they divided the healthcare workers into 2 groups: those who were exposed to aerosolization generating procedures versus those who were not exposed to aerosolized generating procedures. So this was in about 6 hospitals in Toronto. 624 healthcare workers who took care of SARS patients were identified. There was a total of 45 SARS patients, and out of which 10 SARS patients were intubated. Out of the 624 healthcare workers, 26 developed SARS. So what they found was that tracheal intubation was is a high risk, and the odds ratio of developing infection is 6.6 when compared to those people who are not exposed to this aerosol generating procedures. Suction before intubation was in the odds ratio was 3.5. Non-invasive ventilation, it was 3.1. Chest compression was 4.5. Manual ventilation before intubation, that is bagging before ventilation, before intubation, odds ratio of 2.8. Mechanical ventilation has a decreased odds ratio because there is not much aerosolization after the patient is fully intubated. So the best way to limit contamination to the healthcare worker is to use powered air purifying respirators, and the head, the neck, everything has to be covered because this is a high-risk procedure. Also, controlled air purifying respirator is also another alternative. So what are the indications for intubation of COVID-19 patient? So this is like a judgment call. There is no definite rule. So the clinicians must weigh the risk of premature intubation against the risk of sudden respiratory arrest with a chaotic emergency intubation, which exposes staff to a greater risk of infection. So when the patient is obviously in severe respiratory distress, that is the indication for intubation. Hypoxemia, that is refractory to oxygen supplementation. patient is on 100% non-rebreather face mask, 15 liters a minute, is still setting 85, 86, that is an indication. Patient with altered mental status, encephalopathic, that is also an indication. So determining the need for endotracheal intubation for COVID-19 related respiratory failure, impending airway obstruction, signs of unsustainable work of breathing, refractory hypoxemia, hypercapnia, encephalopathy. There is also additional consideration. So what is the trajectory of the deterioration? Patient is on like 2 liters a minute, satting 92%. Then he requires 4 liters in half an hour. In another 1 hour, he requires 6 liters per minute. So when he is rapidly deteriorating, that is an indication for intubating the patient. So emergency tracheal intubation in 202 patients with COVID-19. This was a study which was published in British Journal of Anesthesia. These patients were taken care of in Wuhan, China. So all the healthcare workers had full personal protective equipment like PAPRs, CAPRs. Rapid sequence induction was used with an intubation success rate, 89% in the first attempt and 100% overall. So experienced anesthesiologists with at least 5 years experience were involved in the intubation. That is very important. Hypoxemia was common during intubation. 73% of the patients became hypoxic during the intubation. Hypotension occurred in 18% of the patient during intubation and 23% after intubation. And 4 patients developed cardiac arrest. That is 2% of the patient developed cardiac arrest after intubation. Pneumothorax happened in 6% and about 10% died within 24 hours. So before intubation, out of the 202 patients, the PaO to FiO2 ratio was less than 150 in 96% of the patients. The ventilate rate was more than 30 breaths per minute. And about 8% were hypotensive and about 13% were unconscious. So patients with COVID-19 should be regarded as having high risk of presenting potentially difficult and complicated intubation for the following reasons. When a patient requires intubation for acute hypoxemic respiratory failure, their compensatory mechanisms have already been exhausted. So it is common to see a patient who has a low O2 sat quickly decline after loss of spontaneous breathing. When we give the paralytic agent, they will just quickly desat. So due to strict infection control and urgency of intubation, a careful airway evaluation is frequently not possible. The personal protective equipment mandated makes the performance of the procedure clumsy, which may easily compromise the intubation process. Strict infection and traffic control restrict backup supplies and helpers from being readily available when they are needed. The psychological pressure related to concerns of cross-infection challenges the providers, which may make an otherwise easy intubation complicated. Preparation. Ideally, place the patient in a negative pressure room. That is the ideal. If a negative pressure room is not available, place the patient in a single room and close the door. Hand hygiene is important. Full personal protective equipment per guidelines from CDC. Usually a PAPR or a CAPR with, you have to cover the head and the neck. If possible, second intubator wearing PPE, full PPE should remain outside the room to assist with anticipated difficult airway. Prepare medications outside the room have ventilator available in the room prior to intubation, optimize patient position for intubation. If a difficult airway is anticipated, a person capable of performing emergency surgical airway should be available. So what are the equipments? Endotracheal tube size 7.5, mostly in females, and 8 millimeter in males. These endotracheal tubes can get clogged easily because they don't frequently suction these patients. So the bigger the tube, the better. We have to use video laryngoscopy for intubation, so that direct laryngoscopy, your face is very close to the patient's face. So video laryngoscopy is advised, and there should be a supraglottic airway available if we cannot intubate the patient in the first attempt. A direct laryngoscope and a viral filter, HEPA filter, suction, endotracheal tube holder. And so this is, this is the yellow thing is the viral filter. So we are attaching this viral filter between the face mask and the ambu bagging. So, it is advised not to bag the patient, but sometimes if we cannot intubate in the first attempt and you need to, if the patient is severely hypoxic, we need to bag the patient. So medications, the vasopressor infusion may be needed for patients with hypotension or hemodynamic instability before or following the administration of RSI medication. So an norepinephrine drip has to be ready. Induction agents, propofol, etomidate, and ketamine. Propofol causes hypotension, so usually we avoid unless the patient's blood pressure is very high. Ketamine is the preferred agent because it increases the blood pressure. Neuromuscular blocking agents, we use a higher dose. Their usual dose is succinylcholine is 1.5 milligram per kilogram body weight. We use like 2 milligram. Or rocuronium, usual dose is 1.2 milligram per kilogram. We use 1.5 milligram per kilogram because we frequently underestimate the patient's weight, and plus we want the patient to be apneic quickly, and the patient should not have any cough or anything. So the dose of the neuromuscular blocking agents is a little bit more. Intubation. The most experienced and skilled provider should intubate the patient. This is not a situation where a resident, this is not a teaching situation. So minimum number of people has to be in the room, usually a physician, intubating physician, a respiratory therapist, and a nurse. Only 3 people, the minimum number of people, it is better. Pre-oxygenation with 100% non-rebreather mask for 3 to 5 minutes. Use video laryngoscope for intubation. Rapid sequence intubation. Avoid bag mask ventilation. Attach a viral filter immediately after intubation. Avoid auscultation to confirm endotracheal tube position, because through the PAPR and CAPR you can't use, and plus the stethoscope also can act as a fomite and transmission. Confirm tube position with capnography. Initial ventilator settings should be suitable for patients with ARDS. Most of them patients have ARDS. So the low tidal volume, 6 to 8 ml per kilogram of ideal body weight. Plateau pressure should be less than 30 centimeters of water. Initial FiO2 can be 1, and then it should be titrated to keep the oxygen saturation above 92%. Post-intubation, consider placing the orogastric tube and central venous CVP line. At our hospital, the intensivists have asked the ER physicians to do the CVP line so that everything is done, so that when the patient goes to the ICU, another provider, like another physician, need not get exposed to the patient. order chest radiograph, and another important thing is doffing. Most of the risk of transmission increases while doffing. Doffing is a high risk situation. The viral particles are on the outer surface of our PPE. So if we don't doff correctly, there's an increased chance of contamination and the healthcare worker getting the infection. Barrier enclosure during endotracheal intubation, like aerosol box. It's a plastic tube designed to cover the patient's head. This might diminish the contamination to the providers. So this is a AeroGuard barrier device. This is how it is. There are two openings, and the provider's hands goes into the two openings to intubate the patient. But there are a lot of disadvantages. The box restricts the movement of the hand and would require training before use in treatment of patients. Heavy and bulky plexiglass is difficult to carry and position or reposition in the emergency situation. And if the patient, if the intubation is not successful, they might require additional manipulation, mask ventilation, and with the box, it is not ideal. And plus suction and all those things cannot be done. So those are the disadvantages with this box. So clear plastic drapes, the use of inexpensive plastic drapes may be considered by the healthcare providers as an additional precaution. In summary, COVID-19 should be regarded as having a high risk of presenting potentially difficult and complicated intubation. So protect yourself. Think about the main principles, including minimize aerosolization, maximizing first pass intubation success, and to limit contamination. Thank you. I am open for any questions.
Thank you, Dr. Ryan, for that excellent talk. And we are ready to take questions now. I'm looking at the chat here, and I would start with the first question from Dr. Amisha, who's an ER doctor from Arizona, and asking, are we seeing any evidence related to early intubation in the ER versus holding off? We have heard some physicians talking about how the vent may be causing more harm than good. So Dr. Einstein talked a lot about intubation. Would anybody like to add to that, to answer that question, please?
Sangeet.
Sure. So I mean, Dr. Einstein, you just spoke about intubation. So if you'd like to take the question, that.
Yes, I would like to take the question. So
Sure.
the thing is, it's a clinical judgment. Patients, some of them are like hypoxic. Patients will have 86% SAD, but they are texting. They are not in distress. Silent hypoxic. So those type of patients, what we do is we put those patients on 100% non-rebreather face mask and send to ICU. And in the ICU, they might put them on non-invasive ventilation. They will put them on high flow or BiPAP or CPAP on those patients. But we don't do those BiPAP, CPAP, or high flow in the ER because one, it is not a closed circuit in our emergency department. Second, during transportation from the ER to the ICU, there can be aerosolization in the elevator and other places. So, if the patient is in distress, we intubate. If the patient is not in distress, if they are still hypoxic, but they are when they are not in severe distress, and if they are still hypoxic, we admit them in ICU and closely monitor, and that's what we do. So we have not encountered any adverse events by doing this.
Thank you, Dr. Einstein. Next question.
Can I add to that for a sec, Seema?
Please.
Sure.
Yes. So I think early in our understanding, so weeks ago, I think there was sort of a pendulum swing. Initially, the messages were that we should intubate early, and that was the message we kept hearing: intubate early, and don't let them suffer in any way, partly for the patient and partly for safety reasons. And I think that pendulum has sort of swung back to just good clinical judgment, like Dr. Einstein was saying. And I think different centers have different abilities to contain aerosol. We only have 2 negative airflow rooms, so we kind of have to intubate and control aerosol. We do have an intubation team that circulates in PAPRs and intubates all over the hospital instead of having individual physicians doing it. So one team is responsible for that. And then there are now I just want to mention the helmet BiPAP and the BiPAP filters for viruses that can be done. But again, how do you transport the patient? So we generally do the high flow nasal cannula oxygen and then intubate if it's absolutely necessary.
Dr. Krishna Kumar, you want to add anything?
We would like to avoid as much as we can not to do intubation, keep them in a prone position and give them an oxygen. I mean, Rangila, she is right. I mean, there was a time we used to intubate a lot. Nowadays, we try to avoid as much as we can intubation. It's not a good thing for the patient.
I'd like to add here, New York, when they asked retiring doctors, Dr. Krishna Kumar went back and volunteered, even though his age-wise is not eligible, and he got COVID. Next question to Einstein and Sangeeta, you both did not get COVID, and I think that's really, we had to give a gold medal for both of you. Anything you can share?
Well,
Yeah.
Go ahead, Dr. Einstein, go ahead.
Yeah, frequent hand washings, and we mask all the patients. Universal masking was adopted at our hospital. So everybody wears masks, all the healthcare providers and all the patients in the ER are masked. And we take everybody is having COVID. All patients are having COVID and take sufficient precautions.
I have to also say, you don't know we haven't had COVID. We just we make
We
one
are
of those
asymptomatic.
yeah. So who knows? Now I think we're all looking back in February. I was really sick for a week. Maybe I had it then, and we're all hoping that we're done with it if at all possible. But yeah, I think the universal masking really brought down the worry in huge ways. I think it's really sad to see places where physicians and all staff are actually getting pushback. In the early days when all people were saying is everybody should have a surgical mask, everybody should contain their own droplets, and there was pushback because of supply issues. And I think those were just really, really bad missed opportunities. Now I think that we're all a little more on top of it. I think our risk, I actually feel safer being in the ER than I am in the grocery store at this point, because we are all protected and we're taking so many precautions.
And next question, I think about cell phone, how to sterilize.
Okay, so I'm a little OCD about cleaning stuff anyway. So even before COVID, I would clean everything. As soon as I come out of a patient's room, I would be wiping everything down anyway. But so there are multiple things. One is the cell phone can go in a little plastic cover or a Ziploc bag, even at the beginning of the shift. And then there's alcohol or other wipes in between. The UV box, I think someone mentioned in the chat room, we put everything in the UV box, stethoscope, pen, cell phone, everything. And we're lucky we have one in the ED dedicated. Not everybody does. But yeah, just an alcohol swabs, if you have them, that'll do it as well.
Most of the ER, they have a purple PDI boxes. We use that all the time.
Seema, you have any? There's one question here. How about intubation with video devices like a glide scope without need to look into the mouth? Most ED and anesthesia are doing this now. This is from Dr. Ramamurthy Chilmamli, the neonatologist.
Yes. We use video laryngoscopy exclusively because, your face is not close to the patients face. So that is what is advised, and that also improves the visualization of the epiglottis, and it also improves the success of the intubation. So, but also it also depends like what they are used to. You know, if a physician is not used to this video laryngoscopy, you know, this is then whichever laryngoscope which they are comfortable with, they should use that in this situation.
See many.
I don't see anything else.
I can ask question about oral steroids. Do you see any? Is going to be my mission now on outpatients. Because even today I have a patient who's went to all over the Florida and Michigan. She was treated 2-3 times, and now her antibody is positive. And do you see giving oral steroids any risk, any flare up like you hear from their COVID gotten worse? We're talking about day 4th to 11th.
I haven't seen it personally, but I have to say we're not doing the follow-up with patients. So I actually feel like this question, maybe Dr. Einstein or Dr. Christian has something to say, but I feel like community docs who are seeing them outpatient may have a good answer for that. I don't think we're seeing many people who are being put on steroids, honestly. No. Most people are not still. So I don't know that I even have a good answer for it.
So
yes, we should follow the CDC guidelines. Everything is working, nothing is working, hydroxychloroquine working, prednisone working. I mean, penicillin's going either side. So I think the time will tell us what we should be doing it.
Dr. Einstein?
So, you know, steroids is used only for hypoxic patients, you know, and most hypoxic patients are admitted to the hospital. So we don't start any steroids and discharge the patient. And, you know, some patients who have asthma, COPD, and they need steroids, they might be put on steroids, but we don't routinely put anybody who is not hypoxic on steroids. And patients who are hypoxic need to be admitted to the hospital, and in the ICU, some of them are put on steroids.
And yeah, any questions, Seema?
I see a question here. Are you offering tests to asymptomatic patients who present to the ER, or perhaps to those that request it? Dr. Krishan Kumar, would you like to take that?
Not in the ER, but New York City has opened up the testing to anybody who lives in New York City. He can get the blood test done. He can also get nasopharyngeal swab test done too. Anybody can walk in and get it done now. It was not there 2 months ago. Right now, this New York City has opened up its door. Anybody can get it done. You need to be native of New York City.
I think walk-in clinics are offering all communities.
Yes.
Every town, even small town, my town.
Even Medicare is covering all the older people over than 65.
How about anticoagulants, right, from ED?
These are all controversial topics.
So,
about
anticoagulants, you know, the patient is like very hypoxic, and you know, there are a couple of COVID patients who had PEs. In addition to it, those patients were started on it, and sometimes patients who have elevated D dimers and you know, who are intubated and all those things, you know, in our ICU they start them on anticoagulants, but we don't routinely give anticoagulants for every patient in the emergency department.
How about, there's a question about antibiotics.
So
both
antibiotics, you know, sometimes if we think that the patient has a bacterial pneumonia, we are not, initially, you know, the COVID test took like 24 hours for the results to come back, and, you know, So then we used to start them on antibiotics, azithromycin and things like that. But now if the COVID test is positive and, we don't start on any antibiotics.
No,
But later on in the ICU, if the patient's procalcitonin goes up and if the patient develops ventilator-associated pneumonia and all those things, then they may start them there, but we don't routinely give it unless we suspect any bacterial infection.
I think we're using antibiotics kind of for what they should be used for, is if we see a bacterial infection. The rate of secondary bacterial infections in COVID seems to be less than other disease processes. There's certainly, we saw a lot of co-infection with influenza and patients who would test positive for both. But we're seeing way more of the viral pneumonia. So I think antibiotics are really only if you're seeing something bacterial. The procalcitonin gives us a clue, and we usually get that straight from the ED as well. The rapid test, once the patient is severely ill, we are seeing a huge number of false negatives. Patients who have just florid viral pneumonia and are horribly sick will have negative rapid PCR tests. Sometimes the 24-hour one will come back positive. We see that a lot, that the 24-hour comes back positive, but the rapid is negative. So a lot of it has to go with clinical judgment too.
There's a question. Go ahead, Sima.
Question about hydroxychloroquine over here. It's being used in India and Brazil still, but there's a controversy over here. So could you please clarify the controversy regarding hydroxychloroquine use? Anybody who wants to take it?
No.
CDC is not recommending hydroxychloroquine. Okay. WHO has dropped use of hydroxychloroquine. India, everybody is using it. Even Trump used in America too. Most of my friends, they took hydroxychloroquine because they had a fever and a sore throat, thinking they might have COVID. But unless until we come up with a firm recommendation, it has to be double-blind control studies. It's very hard for us to say it is safer to give hydroxychloroquine or not. I took it. I survived. So can I make a generalized statement? Answer is no, I cannot say it.
One
I think
question.
hydroxychloroquine, in prophylaxis, it might be useful, and early in the disease it might be useful. But they are doing some studies, recruiting healthcare providers and other people who are exposed to COVID-19 patients, and they are being given hydroxychloroquine prophylaxis. And the results of those trials will be, published in the next couple of months. That will show whether it is useful as prophylaxis. But as treatment in admitted patients, it didn't show any benefit in many studies.
So there are a couple of questions over here about triaging patients in ER, COVID positive versus not positive. Do you treat all of them as COVID positive because the chances are they could all be, or how do you keep them separate?
We don't keep them separate. We get them in, get them out. And
The voice is not.
in the ER, we presume.
Can you hear him?
Can you hear me now, Lokesh?
Yeah, I can hear you now.
Anybody who comes to the ER, we presume the patient got COVID infection. COVID infection comes, Rangila said that. It has so many atypical presentation we are learning every day now. It's very hard for us to say what the patient got it, but they didn't get it. So please treat as if they got COVID-19 infection. Let the lab disprove or prove patient has it, patient doesn't have it. First of all, we do not advise anybody to come to the ER for sore throat. We do not ask them to come to the hospital for the fever. We don't ask them to come to the hospital for vomiting and diarrhea. Unless until they are dying or shortness of breath or really severe chest pain, please stay out of the ED. If you didn't have the COVID-19, you will get COVID-19 in the hospital. This is a bad virus. Okay? You try your best not to have a waiting room, as a matter of fact. I like the old style Indian medicine. What was that? You treat everybody under the tree. What that mean? There's open air. So nobody can get infection from each other. The wind is the biggest benefactor to us. As long as the wind is blowing, you can have the patient there and they're not going to get infected. They're not going to give it to anybody else. The problem is in the hospital, we keep on breathing in same recirculated air. Unlike aeroplane. Aeroplane nowadays, the latest 747, 787, 777, they have a 30 to 40 exchanges per hour. That to 50% of that is all the time fresh air. And that air is filtered through the HEPA filter. But in the hospital, there's hardly any air exchange. Unless until the whole hospital is negative pressure room, hospital. Only then you can survive. Otherwise, the air inside the hospital is not good. We tell people, please don't come to the hospital at all. I got COVID-19 in the month of March. We got caught by surprise. We didn't know that. It is so bad. I got infection in the month of March. That time it was just starting, COVID-19. Now, everybody learned from New York, what New Yorkers went through. The rest of the country got benefited. All right. That's why Rangila as well as Einstein didn't get it. Right? Because
that is like,
we were better prepared. We were not better prepared. In 2 days' time, we ran out of the PPEs.
But Einstein is got virus early in Washington, Seattle.
Yes.
Yeah.
They're well protected.
I think he scared the virus there.
yeah, I do think New York State and Washington, thanks to those two coasts, the rest of us really had so much opportunity to learn from that. And I think the biggest message out of both Washington State and New York, New Jersey area was that everything is COVID. Whether it's an ankle sprain or a chin laceration, just
That's correct.
COVID.
He got chin laceration because he felt dizzy. This is because of COVID. That's why he got chin laceration.
Can you comment on second wave?
So what is second wave? I really do not understand what is the meaning of the second wave here is.
We never stop.
New York took its toll. So New York went through a very bad time. About 30,000 people died in New York. And people who did not get hit, now they might get hit in the fall time. Why? Because eventually they have to come out of the house. When they come out of the house, they go to the mall, they go to grocery store, they might get infection. That may cause them to fall. That may cause them to get victimized with COVID-19, not otherwise. So virus is not going to come back to New York from Washington State for the second time, second wave.
Dr. Shah is asking, suggesting, do you keep a mask when you're in a hospital office because of circulation, even though you're not with the patient?
I'm COVID-19 positive. I keep a mask on.
Okay.
And 995. Keep it on, please. You never know. They said there are 3 strains of COVID-19 nowadays, mutated ones. I got immune to one, who knows, rest 2. They might be looking out for Kumar again in the future. Who knows? Better to be protected. Best thing to do right now, work only 1 day a week in the year, not more than that.
Well, we can't afford.
Yeah.
There's one case question about COVID tests, and how about those who are COVID PCR negative?
See, I have
Or COVID PCR.
who are PCR negative, still they have typical presentation of COVID-19. They were treated like COVID-19. Lab test does not mean anything if clinically patient fits into that category. Maybe Rangila as well as Einstein can share their experience.
So the PCR test has to come from the nasal swab. So it depends on getting a good sample, which is generally quite uncomfortable for a patient, number one. And then the rapid has to get run within 15 minutes. So it has to get from patient to lab processed in under 15 minutes. all of these really lead to some possibilities of error. Also, you have to be able to pick up that PCR in the nose at the time of the swab. So we might be seeing the later thromboembolic effects of a patient who had COVID, and maybe if we had the reliable antibody test for everybody and knew how to really interpret that, we might see that be positive and see COVID toes. The other thing I have to say is COVID toes are not just COVID. It could be hernia or chilblains from other disease processes. So I just want to mention that as well. We got to keep that in mind.
You may want to ask.
There's a question about stats on number of days on ventilator and chances of survival. Any information on stats? Number of days on ventilator can increase survival, or what is recommended?
We can add, there is a study recently came out from Harvard. In New York, before it was said that almost 65 older, 95% did not come out. Now they went to look at the experts in Massachusetts, I think around only 18 or 20%. So that's a good news. That's what I learned from the other article. The next question about, I think this is from Dr. Saraswati Mukuna. If a patient came with ruptured appendix cases or other emergency cases, more in ER, so as you are practicing in the emergency room, they're scared of coming to the ER, coming very late. So what happened to the other patients? Can you share your experiences? Because there's so many other emergencies, how the situation?
I would like to take this because we're seeing this a lot. And we're in the Midwest, so we actually have very low ED volumes right now. We didn't get hit hard like the two coasts did. So we actually have plenty of capacity to see patients right now. But yes, we're seeing very late presentations, appendicitis, simple things like diverticulitis that could have been treated with antibiotics now are perfed and have to go to the OR. Completed MIs that present 3 days later in florid CHF where they could have potentially been treated. Strokes that are presenting way outside the window for TPA or any other intervention. Pelvic fractures who were over the phone. It's really hard to give advice to a patient because you have to balance all the risks. But yeah, patients with a pelvic fracture who stayed home for 3 days, didn't ambulate, ended up coming in with not just the pelvic fracture, but also now a DVT because they couldn't ambulate properly. So I think, I mean, it's a difficult advice to give a patient to stay home or go in, but I think we have to really weigh all those risks and hope that it's a physician who knows the patient well. And I really, the need for a primary care physician relationship is just, the importance of that, I think, is more and more evident.
There's a question about any information or comments on lung transplant for COVID for people with extensive fibrosis. Anybody has any experience with that? I don't know.
There's a question on have the ER doctors noticed a widely reported drop in myocardial infarction patients?
No, nobody wants to come to the ER.
Yeah.
The volume is down. I mean, it looks like the ER looks like right now it's a ghost town.
Oh.
You could not even walk through the hallway. The body's here, body there. Now you have a luxury. I mean, nobody wants to come to the ER. They got so scared because of media. And surely we are not seeing MIs. I don't know what happened to MIs. I don't know what happened to the strokes. You're not seeing strokes at all. I don't know what happened. All of a sudden, COVID cured the strokes or COVID cured the MIs. It is a big fear out there, COVID-19.
Dr. Kumar, there's a question for you. Do you tested for antibodies?
I did.
Is it positive?
Positive.
IgG. What is the reliability? Some people saying there some are positive, some patients, even though they have positive, they're not developing. sensitivity, specificity, any information?
See, first of all, none of these tests are FDA approved. They are working, they are operating under emergency, I think, utilization authorization, something like EUA. So those are not very standard tests. And company, they're claiming they are doing the testing. Today I read the CDC said, you take your own gas 50% time. You may be positive, you may be negative. This is a game of the luck. This is what it is. I got my antibody test done first time, Lencor, that was negative. I repeated myself 2 weeks later. It was positive from my hospital. It came out positive. All right. Dr. Avinash Gupta said he was nasally positive, but antibody negative. If he goes to the different lab, it may be positive for him too.
Yeah, what I was told is first generation antibodies have a lot of also, even Roche and other labs, a lot of negatives. Now they're coming with the second generation. They're waiting with the spike protein. Even from India, they're looking from saliva. They applied for FDA, one of my friends said, and they have high sensitivity. So I think they might need 2-3 generations of these tests to get it right.
That's correct.
That's a big challenge.
Question about role of IL-6 blockers and also about remdesivir.
And do they give an emergency room?
No, we don't give those medication in the emergency department. You know, once the patient is admitted to the ICU, the intensivist makes the decision to give those medications.
So just want to comment real quick that the remdesivir study had a few issues because the original endpoint was not length of stay in the hospital. The original endpoints, I think it was mortality. It was not the length of hospitalization. So they switched endpoints during the trial, which
was not
raises a lot of questions. Yeah.
Yes, yes.
So I'm not saying it's a bad drug. I'm just saying there were issues with that trial.
Patient comes to ER with diarrhea, would you test for COVID?
Absolutely, yes. Yeah, we see that a lot. And that's the diarrhea has made it onto the CDC list of symptoms. So yes, we see that a lot.
See, COVID-19 virus, where it came from? It came from the stool of bat. So that's why the many humans are getting diarrhea too. So diarrhea is one of the prominent features of the COVID-19 infection. You should test it. The thing is, if you test positive, you test negative, what do you do next? All right? Still you stay home. Still you observe social distancing. Still you have mask on your face and hand washing, routine care. That is all you're going to do anyway. Unless until you're living with somebody who's immune compromised or who's over age 65 or he's got a bad liver disease or he's a severe kidney disease or you got a CHF, okay, or you got a emphysema, or the person is pregnant, or the patient got chemotherapy, or the patient got leukemia, or lymphoma, any kind of cancer. Those are the special population you should be watching out for. Those are the patients, they should be really restricted and isolated and quarantined at home. Okay. Whereas the younger people, they don't get COVID-19. My daughter, she is second year medical student, not medical student, medical resident. She was running the COVID floor. She didn't get any COVID. Young people, they tolerate COVID very well.
And this question for Sangeeta and Dr. Einstein. How do you isolate at home yourself?
Go ahead, Dr. Einstein.
Yeah, so you know, at our hospital they give scrubs to us, so we change to hospital scrubs, and at the end of the shift we go and dispose the hospital scrubs, take a shower, and then put on the clothes which I brought from home, and then go home and I was isolating myself at home.
Sangeet.
So my husband is an interventional cardiologist. He does ECMO. So, and we work in the same hospital.
So then,
And we have two teenage kids. My in-laws, they decided to stay with my brother-in-law. A lot of information, but we just decided to take the risk amongst the four of us, two teenagers and me and my husband. And so we change, we come home, go to a different bathroom, enter through the garage, leave everything there. I mean, it's just this crazy routine of wiping and washing multiple times on departure from the hospital, and then re-entry into the garage. There's one process, entry into the house, another process, big gardening boots that can be wiped down. I mean, it's crazy.
and Dr. Einstein, you mentioned cheap plastic barriers as a method of preventing aerosol spread. And there is a Dr. Melik shared a technique of passing HFNC through a clear plastic bag, which extends from head to waist level. Is any comment? Is just a statement? Is anyone else in the CME using this technique?
I haven't honestly seen that. We do use a lot of cheap plastic. We actually bought the 97-cent emergency ponchos from Walmart. It has two armholes you can put your hands through, cover the patient, and try to contain the aerosols a little bit. But with the high flow nasal cannula, I've not seen. I'll have to look at that though.
I mean, in our allergy office, we give allergy shots. We have not stopped. After 1 week, we opened. So there is like a plastic curtain, like a shower curtain, and the patient comes, they give the shots through that. So, and all our receptionists are completely closed off except small, taking the cards. So that's what things we did. A lot of outpatient offices are not open actively. I think this week they started opening more and more. And we never stopped except first 1 week we opened back again.
How and when you clear a COVID patient to go back to work?
Again.
Or what is the protocol of your hospital?
Yeah, the protocol is they must spend at least 10 days in isolation. 10 days plus 72 hours if they are afebrile. Only then they can go back to work. For that, you don't need any testing. Ultimately comes out to 12 to 14 days of the isolation that they can go back to work. Some of them, they may be still symptomatic even after 2 weeks. So if they're not clinically good, they're not going back to work. They're staying home. All right.
And I don't know, the OBGYN question, if they have a mother is pregnant positive, after baby born, what happens? Who will take care of the baby? Parents or mother?
Well, baby should be away from the mother as much as you can. Okay. Mother can stay in separate place. Baby should be cared by somebody else in the family, maybe family member, maybe grandparents, maybe father, maybe somebody else. Okay. Baby should be isolated from the mother as much as you can.
Yeah.
Many people here are wondering why incidents of COVID and also deaths from COVID are lesser in India than in USA. Any comments on that?
See, first of all, we cannot compare India versus USA. Second thing, the incidence is less because there's less testing there. If you don't test, you're not going to diagnose them, they got COVID infection. Secondly, India got a population of how many people?
1.3.
Yeah, 130 crores. At least 25, 30,000 people die every day. How many of them they get tested for COVID-19? Hardly any. So statistically, I mean, it's kind of skewed number. So who knows what the real story is? All right.
And also they don't report, like private hospitals, they don't report even there is suspicion, or the government hospital, the collectors have a pressure not to report. In Telangana state itself, they stopped testing. From the high come the chief minister, there's a big pressure to test more, but he stopped completely and cut down significant. So there is even the families don't want to show them. If in case if a person dies, they just don't want. They just go ahead and bury it rather than COVID because of a stigma. That's the biggest issue. So we're never going to know the deaths, actual numbers, never ever in India. It's always will be low.
Forget about India. Go visit China, birthplace of COVID-19 in Wuhan province. How many deaths they declared? 3,000. And you know, one of the cell phone company was said, they said they're looking out for 2 or 3 million people who are cell phone holders. And we cannot find their accounts anymore. And that's how the people came to know the number that what China is reporting, 3,000, is totally wrong. It's cell phone company who issued the cell phones to 2-3 million subscribers, and they're not responding anymore after a couple of weeks. Then what happened to them? You know, in the Wuhan, what the Chinese government did, they locked down the whole city. Nobody can get in, nobody can get out. People are locked up in their houses. And they report only 3,000 deaths. You can make a guess.
This question about biological agents, rheumatoid arthritis patients on hydroxychloroquine are biological. Do they have lesser COVID severity patients that you see in ER? You see any less rheumatic patients or other patients with COVID or more? Dr. Einstein, Sangeeta, anyone?
I mean, it's very, very less. I cannot say that I am seeing so many rheumatoid arthritis patients to compare what happens before and now. It's very, very difficult.
And also France, they said smokers versus non-smokers. So smokers they have not seen increase in the COVID. Do you see any COPD and asthma more than usual in?
All COPD patients and asthma patients, we test for COVID, and some of them come back positive. So we don't know whether, it is increase or decrease, but we see some patients who are COVID positive and some patients are negative. So
When you see diarrhea patients in ER, do you send stool for coronavirus PCR?
no, we only do the nasal swab. We don't do the stool coronavirus. From the ER. If they are admitted, they might send the stool from there.
Any recommendations for pregnant patients with COVID?
Universal standard precaution, that's it. Isolation and strict hand washing, masking, not going outside, take shower twice a day, change your clothes twice a day. That's routine precaution, nothing else you can do.
There's a question about ECMO. Where in your hospitals, there is any experience in ECMO patients, how survival rate and beneficial rate in your hospitals? You can comment.
So there were like 2 patients who were referred to ECMO from our hospital, and both of them survived. And one was a physician. He was a 45-year-old ER physician. He went into multi-organ failure. He had his ejection fraction was 20%. He had severe ARDS. He had renal failure. And he was sent to ECMO, and he survived. He's discharged from the hospital. So.
And this question about what are the prognostic factors, bad prognostic factors to the mortality? Is any particular factors that we can follow in the lab test? Or?
Sorry, just one last thing about ECMO. I think some of the guidelines were that patients over 50 were not going to routinely get ECMO, which of course is kind of ironic that a lot of the cardiologists who do the ECMO are over 50 themselves, but the survival rate was not expected to be very high for that population. So sorry, go ahead, next question.
No.
So the prognostic factors, elevated D dimers, if the patient has, elevated ferritin, D dimers, And if the patient has acute renal failure, these are all bad prognostic factors because it indicates cytokine storm and elevated troponins and elevated D-dimers. They're all bad prognostic factors. And advanced stage, multiple comorbidities are all also.
How about obesity?
Yeah, obesity is a very important risk factor.
I would say it is one of the worst predictor, obesity.
Yeah.
Most of the people who die, they are pretty obese
Do you know how that works? Why?
because they have less respiratory reserve. They are stressed out because of the overweight. The lungs don't tolerate.
There's another question here about elevated D-dimer, heparin versus anticoagulation. What do you do? Or do you do anything?
So, at our hospital, they start them on anticoagulation. Heparin is useful because it also has some anti-inflammatory effect. And plus, if the patient has renal failure, the Lovenox and all those things has to be adjusted. And the patient, when they are discharged from the ICU, they are put on oral anticoagulant for like 2 weeks. Because some of the patients, one of the patient had, he came out of the ICU and he was doing fine and suddenly died, So this was in initial days in the first week of March, and they thought he might have died of PE. So that's what.
And a question about how can we allow nannies at home and what precautions?
Most important thing is they have to wear face mask and they don't have any symptoms.
They can bring corona home too if they are asymptomatic. We don't know.
Face mask.
How early patient should go on ECMO?
Let's take the lead on this. You don't deal with them.
Dr. Einstein, do you have anything?
Yeah, if they have refractory ARDS and if the patient also has multi-organ failure, these those were the two criteria we referred for ECMO from our hospitals. And so main thing is refractory ARDS. When the intensivist feels that the patient has severe ARDS, not responding to ventilator, and they have a good chance of survival, then they send to ECMO.
This question about the masks. Do you wear N95 if you're seeing in office, or they may not be COVID patient? Do you advise everybody wear an N95 even regular office?
Answer is yes. If you can afford it, you should have N95. Gonna go one step ahead, go for P100. You never know, they may not have any symptoms now, but they may give you corona. They better to be better protected. Okay, so please have a mask on all the time. Have a face shield with you. Right? Prevention.
Same thing, Sunita? N95 in the office.
Yeah, I think at a minimum, the patient should have a mask, the provider
Yep.
should have a mask, whether it's surgical or N95. I mean, there's no real downside to wearing an N95. I think the whole reason that surgical masks became part of the recommendation was not based on actual recommendation, it was based on supply chain. So it's one of the times in medical history where our medical recommendations and the CDC itself were making recommendations based on what the supply chain could actually provide. And, you have to decide where you stand on that. I personally wear an ENVO mask the entire shift. I might take it off every now and then, but for the most part, I think physicians who were in close contact, and a medical office is a small area. why not wear the N95? If you're in an area that really has trouble getting it, the supply chains have opened. Those reusable 3M respirators are out there. If you need help getting it, actually the state of Illinois, there was an anonymous donor you can get a half mask reusable respirator in the state of Illinois for free right now. It's amazing. So the supply chain is out there. There's no reason you cannot get an N95. Dentists have trouble right now, unfortunately, because everything's earmarked for healthcare providers and first responders. So dentists, oral surgeons, periodontists, they have a lot of trouble getting N95s. So we have some community groups trying to get a lot of protective gear for them right now.
There's a question, have any of you seen COVID-19 positive kids in ER?
Yeah, I have seen a few patients. Couple of patients were like 2 or 3 year old. They had some cough, runny nose. Their family was positive. We sent them. They also were positive. But 2 weeks ago, we had a patient. I had a patient, 13-year-old. He went to his primary care physician with some vomiting, diarrhea, and he was diagnosed as gastroenteritis, and he was sent home on Zofran, oral Zofran. His pulse rate at the time of discharge from the clinic was 138. The patient was brought to the ER, and the ER, his systolic blood pressure was 60, and he had a rash in his chest. So we gave some fluids, but he's developed increasing shortness of breath. The ultrasound, we put an ultrasound probe, and he had some B lines. So he started the fluids, started him on epinephrine drip, and put the ultrasound probe, and his cardiac contraction was very, very low. His EF was around 10-15%. And he was COVID negative by the swab. He was admitted to the pediatric intensive care unit, and they swabbed him multiple times, and 3 times it was negative. Oropharyngeal, nasopharyngeal, everything was negative. And he was on pressors, and after 3-4 days, he started getting better, and after a week, he got better, and his EF improved, and his COVID antibody was positive, IgG was positive. So it was this, post-inflammatory syndrome in kids. But he didn't have conjunctivitis and other Kawasaki type of presentation. He just had hypotension, and he had a rash, non-specific rash in the chest, and so that was one of the things. But he never had any history of contact with COVID or any other COVID symptoms like earlier. So we were baffled with that case.
I had a kid, 4-month-old kid, came with the URI symptoms. He was COVID positive. We got chest X-ray shows some kind of bilateral densities. But he was studying very well. He was interacting with the mother very well. He was drinking very well on the breast milk. I just sent the patient home and kept a phone contact with the family. And they say he didn't get worse. And over the next few days, he got better by himself. So not all the COVID patients you need to admit. It's better not to admit. People who got admitted to the hospital, they have poor outcome. Rather, people did not get admitted to the hospital. They stayed home. They did just better. Okay. Treatment for COVID-19 is all supportive.
There's a question about ethnicity here. I don't know if you people have any idea about this. What are the ethnic differences in the incidence? And also, there's a question about Asian Indians who received BCG vaccine have protective effect and or lower incidence from COVID-19.
I don't know enough about that to comment.
I think blood test available which can screen antibody and virus. All right. There are some questions about reusing the masks. Touch base on that. Why can mask not be reused? If you let it hang around long enough, eventually the virus will die.
Yeah, so I think going back to the early study about the how long does the virus stay active on different types of surfaces, and I think everybody sort of landed on the 4-day rule. So you use an N95, hang it up, or put it in a brown paper bag or something where it gets airflow, and then you have at least 4, preferably 5 to 7, and then you rotate them. Again, these are single-use masks that a few months ago your hospital would have reamed you for reusing. Now everybody has had to reuse them because they were in such short supply. I think the thinking is that if it's been 4 days, there's not going to be any active viral particle. Of course, that's not the ideal usage. At our hospital, we're using 1 per day or 1 per shift, and then a surgical mask covers it. The surgical mask gets changed. There are definitely places that are using it not just for a week, but for a month. And I was at Cook County for my residency. We used an Essing. You got an N95 at the beginning of your residency, and that was about it. So that's not ideal either. But I think now there's still a nationwide shortage of small N95s, but regular size, there's no shortage. So it just shouldn't happen. But we're hearing a lot of really sad stories, especially house staff and house staff who are on visas who wanted to wear more protection, but a lot, especially in the earlier weeks, this message of you're creating confusion, you're setting a bad example for all the other house staff. We don't have N95s for everybody, so you shouldn't be wearing an N95. And none of our colleges or academies supported that. American College of Emergency Physicians, American Academy of Emergency Medicine both came down very strongly saying we should be wearing the level of PPE that we are comfortable with. The Joint Commission put out a statement weeks ago as well, supporting the use of PPE that people are comfortable with and not to be dictated by someone else. So it should be used properly. There are ways to stare at it, to make sure that it's clean. It's supposed to be fit tested and have a good seal and all of that. So I think there are ways to reuse it right now when we have to, but there's plenty of protection out there.
Somebody also suggested if you have N95, put them in a pressure cooker with some water inside. It will sterilize your N95. But
So
don't put it in the microwave. That is going to burn your elastic. Okay.
I think there was a study that looked at steam, alcohol, different agents, and I think that anything with moisture was less. Steroid was at the high end of it, but it lessens the number of uses you get out of it, and lessens it goes from I think an N95 and then drops to like an N85 or N70 depending on the processes. So yeah.
Lokesh, do you see anything else or should we wrap up?
I think take-home message is, when this episode is over, we as a physician, we should be buying paper for ourselves when the price is right, maybe $200 or $300. Just buy it, keep it at home. Another thing to buy is the ventilator. Just buy it for a few $100. It's going to come down in the prices anyway. Just keep it in a basement. Who knows when you will need it. Okay, and COVID is not going anywhere. COVID is going to stay with us for a few more years till we get herd immunity, till most of the population gets immunized against the COVID-19 vaccine. Okay, so be prepared. COVID is going to stay with us. It's not going anywhere.
There's a question here about vaccines. What do you think when the vaccine is going to come out?
Yes, maybe I'm looking for the spring 2021. Nothing before that. May is gone. Only 7 more months to go for Christmas and New Year. Okay, it on and average takes about 12 months to 15 months for a vaccine to come out. That too, the vaccine on a speed track right now, only because of Trump. Earliest we're looking for vaccine trial in the mass population somewhere in the spring of 2021. All right. Once everybody gets immunized, who knows what would be the effectiveness of that vaccine would be. Every year we take flu vaccine, how much it protects us? Only 10 or 20% of time. 60 to 80% time, flu vaccine does not protect us. If flu is not protecting us, and who knows what will happen with the COVID-19 vaccine. All right.
I think we can recap here. Dr. Einstein, can you say some final remarks?
My final remarks is like most important thing is the patients, who is having COVID, who is diagnosed to have COVID-19, they should have a pulse oximeter and measure their pulse ox. And if their oxygen saturation is low, they need to come to the hospital. We use telehealth in our system. We discharge patients with pulse ox, even if they are satting 97, 98. We discharge them home with pulse ox, and that has picked up few patients. And when they come early, I think they are treated much better, and I think the outcome is better. So that's what I found during my experience, that patients should be discharged with pulse ox, and they have to be monitored with pulse ox, and respiratory rate somebody should monitor at home. And probably when they are hypoxic and they are started on steroids, probably they have better outcome. That's what I would say.
Thank you. That's a very good advice. I just bought a pulse oximeter for my house. Dr. Sangeeta, what are your final remarks?
Oh, she got disconnected.
Okay, Dr. Kishan Kumar, you can take over till then.
So I said that when the price comes down, think about buying a powered air purifying respirator, plus keep a ventilator at home. People who got Samsung, pulse oximeter is built in. So you don't have to buy a separate pulse oximeter. But people should get used to, they should get ready to manage a little emergencies, little disasters at home too. Who knows what the future is going to bring to us. All right.
Dr. Sangeeta.
I think my final comment is a little off the subjects we've covered, but I think we're in an age where we keep listening to the loud voices in the room instead of the most qualified, educated voices. And I think this is a time for all of us to be humble, to know what our limitations are. One of my mentors, her statement was, it's really easy to give an expert opinion. It's really not easy to actually be an expert. And so I think this is a time for the medical community to really stand up. We're seeing what happens when physicians are not in control, when administrators are in control and politicians are in control. And of course, it's a side subject, but I just have to say that once. We need the intelligent, qualified, educated people in the room to help inform all of our decisions. Thank you. And thanks for organizing this. Appreciate this.
And
do you have any comments? Then we can call Dr. Reddy.
I think we want to, my comment is the COVID is outpatient. It has the Lancet journal published Chinese studies. The fourth day, you have the D-dimer increasing, ferritin increasing, LDH increasing. Especially the sick patients 60 to above, they have to come early, they have to talk to the doctor, we have to plan of the outpatient doctors, and then follow them like telemedicine daily, especially the high-risk patients. I have a feeling 90% COVID is outpatient. Suresh, you want to close up meeting?
Yeah, thank you, everybody. Thank you, especially all the speakers, Dr. Einstein, Dr. Kumar, Dr. Sangeeta, and the moderators, Dr. Seema Arora and Lokesh Idara. Thank you so much. And the Chicago Medical Society, thank you for offering the CME to us. And this is a milestone. Today is a milestone in the history of AAPI. And you are the part of the milestone that we have. We are providing the first virtual CME, and this is the way the life is going to be. COVID in a way has brought 10 years ahead of us. Like whatever was supposed to happen in 10 years, we are doing now. The telehealth, the virtual meetings, and more. And the social distancing, it has given a special meaning for social distancing. And I think this will go into the dictionary now, social distancing. But I would rather not use that word. I will call physical distancing, but social closeness. We have become more closer, more stronger, more united. And it gives a special meaning for humanity. All the war was between humans and humans. This is global war, and it's humans versus non-humans. So it's a very humbling experience. Some of our very close friends really went through this struggle, and some are really still extremely critical. And it grounds you. Well, thank you all for joining, and hopefully we can continue. And please join. We are doing a 10-day session, like a CME and non-CME talks, like a marathon starting in the last week of June. That's closing in on COVID. Please join us. Thank you.
Thank you.
Thank you.
Night.
Everyone, good night.
Good night.